of Resolve, the National Infertility Association. We're so happy to provide you this update on the Affordable Care Act and its impact on the infertility state mandates. This week is National Infertility Awareness Week, and it's fitting for us to share this information with all of you during this National Health Observance for Infertility. It's actually the only one that's federally recognized. So if you have a question, everyone is muted on the call today. You will be asked to use a chat box. You will find it up if you open up the webinar screen up on the top right corner. You'll see a little red arrow, and you can click on that, and it opens up a series of things that you can do on your phone, and one of them is on your computer, ask a question in the chat box. So please feel free to ask any questions throughout, and I'll take your questions at the end. So let's get started. Why does Resolve even care about this issue? Well, we care deeply that every person dealing with infertility gets access to medical care for their diagnosis and treatment of infertility. This is a disease, and as such, it should be covered by health insurance. As many of you know, Resolve and its volunteer champions were instrumental in getting the infertility state mandates passed. While they are not perfect, and some of them need to be updated, the mandates have helped thousands of people have children who otherwise would not have. In the past few years, we have worked to get the infertility mandates in Massachusetts, Maryland, and Hawaii updated, and have worked on new mandate legislation in a few other states. Resolve is a member of the National Health Council, which has been very active in insurance reform and the Affordable Care Act while it was being debated in Congress. Resolve followed the work of Congress very closely as it debated the Affordable Care Act. We've been very active in this issue and are proud to say we are one of only a few organizations that really understand the issues and challenges of the ACA as it relates to state mandates. We work very closely with our partners that have government affairs staff here in Washington, as we have very limited resources, and often our partners have had valuable insight on this topic. We interact with and reach out to other advocacy organizations that have many of the same concerns as we do. In February of last year, we hosted the first and only webinar on this topic, and it was a very comprehensive presentation on fact. Really, the bottom line, Resolve is working on this issue, and we strive to provide the most accurate information to all of you. So let's take a quick refresher on the Affordable Care Act, or Obamacare. It was passed into law in 2010, and then it went over to the Department of Health and Human Services for implementation. Now, some of the things that were in the original law have changed since it went over to HHS. Really, the biggest, in my opinion, has been how the essential health benefits have been handled, but there's many other changes that have been implemented by HHS. When the law was passed, everyone thought that the federal government was going to decide what the essential health benefits would be. But when this went over to HHS for implementation, HHS said, you know what? We're going to let the states decide. And they established what we call the benchmark plan framework for how the states will create their own essential health benefits plans. Remember, the essential health benefit plans are only for the plans offered in the state exchanges, which are qualified health plans in the individual and small group markets. So large employer plans and self-insured plans are not covered by the essential health benefits, nor are they part of the state exchanges. In January of 2014, all of these exchanges opened, which we all know what happened there. HHS put its benchmark plan in place, and 2014 and 2015 as trial years. In other words, let's try this approach out. We'll learn some things in those 2 years, and then we'll make adjustments if need be. So, how did this essential health benefits deal with state mandates? Well, that is quite interesting. This slide that you're looking at right now is actually from Avalier's presentation that they did for us in February of 2014. So I give all the credit to Avalier Health for putting this slide together. If you look at what's in the blue, that is what is actually in the Affordable Care Act law as it relates to how mandates are going to be treated. Let's take a look at that. It says that a state may require that a qualified health plan offered in such state offer benefits in addition to the essential health benefits. Then it says if you do that, states must assume the cost. It goes on to say how the state shall make those payments, and they give some examples. And a key word here is that this is to defray the cost of any additional benefit described in that clause. So remember, this was assuming that the federal government was going to pick those essential health benefits, and they're telling the states, if you want to add things to your essential health benefits above and beyond, you're going to have to pay for them. You're going to have to defray those costs. Well, when HHS came out with the benchmark model and basically told the states that they were picking their own essential health benefits plan and not the feds, I think that someone over at HHS must have remembered this tiny little clause in the original law. Remember, that original law was over 1,000 pages long, and someone must have said, uh-oh, and they had to go back and tell the states that they would actually waive this pay-for clause for 2014 and 2015 for any mandates. However, they went on to say that it was only going to cover mandates that were on the books and passed as of December 31st, 2011. I believe it was around 2012 when they came out with this information. So they went back and they said if a mandate existed on December 31st of 2011, you're okay, this waiver applies, and you don't have to, quote, defray the cost. Well, we all breathed a big sigh of relief, and we thought the can is going to be kicked down the road until December of 2015, and then we'll see what happens. Well, how exactly does this pay-for clause even work? I'm showing you exactly what's in the law. There's nothing else. Because of the benchmark approach, the federal government has actually not defined how states might make payments for these mandates. Who are the payments to? What are they for? How are they calculated? None of that is clear. So what happened? The waiver's in place. The states go out and they create their exchanges. Some of them default to the federal exchange because they don't create their own. And most of the state infertility mandates are actually picked up in the essential health benefit plans that all of those states chose that are offered in the exchanges for the individual and small group market. There are two exceptions in that the Arkansas IVF mandate has always excluded HMO plans for whatever reason. And guess what? Arkansas chose one of their HMO plans for their benchmark plan. So it didn't include the IVF mandate. So if you go to the state exchange and get your insurance in Arkansas, you're not going to see that mandate. In Maryland, they had a different issue in that their IVF mandate has always excluded the small group market. When Maryland chose their essential health benefit plan, they chose the largest small group plan. It never had included the IVF mandate. But remember, the exchanges are for the individual and small group market. So they were allowed by HHS to make an exception, and if you go to buy insurance through the Maryland Exchange, you will see the IVF mandate if you buy it through the individual market, but you won't see it offered in the small group market. So there are some exceptions. And let's face it, prior to the state exchanges being formed, if you were uninsured or you were covered under an employer plan that was not subject to the IVF mandate in your state, and now for some reason you are able to buy insurance, you might actually be accessing the IVF mandate for the first time. So in essence, the ACA has to an extent expanded some access to IVF, and as of today, we haven't really seen them restrict any access that we know of other than the examples I've given in Arkansas and Maryland. In February of 2015, in 2016, remember the benchmark plan was a trial period for those 2 years, 2014 and 2015. In that rule, it did address the mandate issue by saying, in essence, two things. It said that the pay-for waiver stays in place through December of 2016, and that date that I like to call frozen in time, December 31st, 2011, is still in place. In other words, any mandate in place as of December 31st, 2011 is waived from this pay-for clause now through December of 2016. So we bought ourselves another year. What we also learned in that rule that came out is that states are going to be allowed to pick a new benchmark plan for plan year 2017. The benchmark plans that they chose for 2014, 2015, and 2016, they get a chance now to change those, because those first 3 years they could not make any changes. So there could be changes that could happen depending upon if the benchmark plan that a state picks now includes or doesn't include the mandate. HHS is expecting states to select a new essential health benefits benchmark plan by June 1st, so just in a few weeks, June 1st of 2015, and that's going to be for plan year 2017. Who knows? Some states may keep the same benchmark. Some may decide to make a change. If they don't pick, then a default will fall in place. And the default that HHS has put in place is the largest small group market plan in that state. Now, HHS is going to publish a list of all the state selections. So all of the states and what they pick as their new EHB is actually going to be made public, probably by late summer, and it's going to be open for public comment. So people will be able to go in and look at those plans and see what they cover and what they include. Following this public comment, they'll publish the final list likely in the fall, and then everyone will be set and will know if any changes are happening, we'll know in 2017. So let me just tell you a little bit about our experience in dealing with the state mandates in this new ACA era. Well, the American Society for Reproductive Medicine and key physicians in California worked very hard to get a fertility preservation mandate passed in 2013. It passed both the California Assembly and the Senate, but it was not signed into law by the governor. Governor Brown cited ACA implementation, which would be pending in 2014, as the reason. This was in August of 2013. But the California legislature had done a brilliant thing. They had carved out the individual and small group market plans so that the new mandate would only affect large group plans. So in fact, it did not touch the essential health benefits and the state exchanges at all. So the governor's reason for not signing it was completely false, since the bill did not impact the ACA at all. It was very frustrating. Now let's move to Hawaii. Hawaii does have an IVF mandate, but it's very old and out of date and needs a lot of improvement. There have been several attempts to try and improve that IVF mandate as well as pass a new fertility preservation bill. They actually get a little closer every year, and we have very dedicated state legislators who are working on these bills and advocates. But this pay-for clause is very concerning to them. In fact, the Hawaii Attorney General's office has called me on several occasions seeking guidance on how they could pass or fix these mandates and get around the pay-for clause. Now let's turn to Maryland. Just in the last couple of weeks, in Maryland, a very influential LGBT advocacy group in the state, which is called Equality Maryland, they successfully got a change to the current IVF mandate, and they got it passed by both chambers, and it actually is awaiting the governor's signature. This is a first-time bill, and it adds a non-discrimination clause to the current IVF mandate that basically will allow lesbian married couples to access the IVF mandate and get it covered. Wouldn't you think this would change the mandate? The Maryland Attorney General and the Maryland Insurance Commissioner apparently have said it is fine. But state legislators did not even know about the mandate issues and the Affordable Care Act when they introduced the bill until we raised it with them. So these are 3 examples, and as you can see, confusion rules the day. So let me tell you what we've learned from some other advocacy organizations, and I'm going to highlight Autism Speaks. Autism Speaks was formed 10 years ago. In that time, they have passed autism mandates in 39 states. The mandates are actually all over the place in terms of coverage, and some of the very early ones are actually not that great, and they need to be fixed and updated. However, since December 31st of 2011, 21 of those 39 states have either passed a new autism mandate or they've amended an existing mandate. And some of those changes were minor, but actually others were very significant. In fact, in one state, the original mandate had autism insurance coverage until age 6. When they amended the bill in amended the mandate in 2013, it changed to age 21. So opened up access and coverage in a very, very big way. Now, Autism Speaks does not know of any state that has had to defray the costs of the mandate, and they're not even sure the states know how to do it. They have had some of their new mandates carve out the essential health benefit plans. So the new autism mandates might exclude the individual and small group market and only applies to the large group market. These have passed, they've been signed into law, and they're in place. This has worked for them in some states that have been really jittery about the Affordable Care Act. Okay, wait a minute. Isn't that what they did in California in 2013 for fertility preservation? Yes, that is exactly what they did that the governor said was problematic. So, what does HHS have to say about all of this? Well, in March, I met with a center. It's called CISIO, and it stands for the Center for Consumer Information and Insurance Oversight. This is a new center that was specifically formed to implement the Affordable Care Act. It's part of HHS. So when I met with CISIO a few weeks ago, I found out that Autism Speaks had actually been there 1 week before me, had met with the exact same people, and now that I've spoken to Autism Speaks, we had, for the most part, the same exact questions for CSIO. So we're not alone in this. CSIO suggested that we work with and through the state insurance commissioners, as they know what will and won't work in their state, and if there are ACA-related questions. Each insurance commissioner actually has a direct contact at CSIO that can answer their questions. So apparently they have a direct phone number and they have a name of a person at CSIO that these insurance commissioners call and interact with to ask questions and ACA-related issues. So when I met with CSIO, I asked them how many states have had to defray any of the costs associated with a new or updated mandate. Again, something that might have passed since December 31st of 2011. And they told me that they didn't have that information and they were completely silent. I'm serious. They didn't even talk. They just stared at me across the table and did not answer. They don't know. They have no idea if any states have had to do this. When I asked them how this pay-for clause is even calculated, I was told by CSIO that the states actually know exactly how to determine that calculation. Well, I don't think I believe that. So I'm starting to sound, I'm sure you're listening to this thinking, I'm starting to sound a little frustrated and a little bit cynical perhaps. But wait, I also found out from CSIO that we actually can make changes to existing state mandates as long as the changes comply with federal requirements. Now there's no list of what these are, and one presumes that you would need an auditorium full of attorneys to figure out what all the various federal requirements are, but that was news. Now, in the last few months, I have spoken to major national LGBT groups and other health policy groups who feel very strongly that non-discrimination issues are okay and comply with federal requirements. Think of the Maryland IVF mandate. But what else? Might there be other things that we can do to change or update our current mandates that comply with federal requirements? CSIO cautioned, again, that the state insurance commissioner is the best and most reliable source for knowledge about what is and isn't acceptable for mandates. Now, I don't know about you, but my experience and the experience of other advocacy organizations is that generally the state insurance commissioner is not necessarily the most sympathetic person to for state mandates, nor are they generally supportive of state mandates. I just put that out there. It's a general comment, but it's something to consider. I asked CSIO about the frozen in time date of 12/31/2011 and if that was ever going to change, because let's face it, it's now 2015. They said they did not know, but they're very open to suggestions on how it should deal with changes in medicine or medical procedures. In other words, they're asking for us to provide them with ideas and input. So remember, this is December 31, 2011, but what happened in 2012 that was pretty big in our community? Well, ASRM said egg freezing was no longer experimental. Right now, CSIO has no room for this medical advance and perhaps mandates that happened after 12/31/2011. So obviously this is very problematic. CSIO does not really want to provide much guidance on this issue, as they want the states to lead and not them. Then why are the states calling me for guidance? And the states have questions. When asked why they don't suggest this carve-out model like Autism Speaks has done and what the California legislature did in 2013, why doesn't CSIO just say, hey, that's a model that could work? They said to me, oh, there's no way we could ever do that. Oh, goodness. So where does that leave us? Where are we today? So we're not going to see any changes at all to the mandates or the essential health benefits through December of 2016. New benchmark plans are going to be picked this year for 2017. That'll be in place starting January of 2017. And we can see, we'll find out this year if the mandates are included in the new plans picked by the states. We do not know, nor frankly does anyone we have talked to, including SOCIO, know of any state that has defrayed the cost of a new or updated mandate. We are not sure states even know how to do it, and even the Association for State Insurance Commissioners hasn't provided any guidance on this issue. I'm beginning to think that no one really cares or takes seriously this pay-for clause in the law. SOCIO doesn't seem to care, the states aren't having to do really anything, and everyone just keeps moving along as if this doesn't even exist, in a sense. Autism Speaks did ask SOCIO when they met with them the week before me, why don't you just get rid of this pay-for clause that was in the original law? SOCIO did not respond to what I think is a great idea. So do we just bury our head in the sand and forget this even exists? No. I think that we've gotten complacent and we take these IVF mandates for granted. We need to make sure that we've protected ourselves. Do you want to form a state coalition with Resolve's help? The coalition will create a way for patients and professionals and all the other interested parties to work together on this issue. I've listed some ideas here on this slide of actions that could be taken this year or next, and there might be even more great ideas. And based on the Autism Speaks example, I think we should go forward with trying to pass fertility preservation mandates, and I think there are opportunities to fix some of the current mandates that need updating or are problematic. They can be amended, so let's do it. So how can you help? We have a huge mission here at Resolve and have a budget of less than $1.5 million a year. We are expected to do a great deal, and we want to do it all and more. The needs are so great. I would ask for you to consider an annual charitable donation to Resolve. In my opinion, if you work in this space, you should support the charity that improves the lives of people living with infertility. Please make sure you renew your professional membership every year. It's a very modest investment in Resolve, but collectively, it helps us greatly. And be proud of your support of Resolve. Use our Proud Partner logo and tell your clients and patients that you support Resolve. Use our content. Link to it from your website and be sure your patients and clients know how to get information on this topic. And be sure to follow us on social media. We are constantly updating our followers on legislation and other advocacy issues. And please stay in touch. If you're interested in helping form a coalition in your state, email me at bkulora@resolve.org. Please contact Resolve for any questions on this topic. You can email us at info@resolve.org or bkulora@resolve.org. Even if we don't know the answer, we'll do our best to find it. We have other partners. I can go to people at the National Health Council. I could go to Avalier Health. ASRM is very helpful. And some of the pharmaceuticals that have government affairs offices here in Washington have a lot of information. So here are some resources for you. Healthcare.gov is the official site of the Affordable Care Act. SOCIO, their website is listed there. They're part of CMS at HHS. And then there's the third bullet there. I can email that to you if you'd like. But that is a link to the content on resolve.org that has to do specifically with the Affordable Care Act. And again, if you email me, I can send you that link. All right. Now I'd like to open this up for any of your questions. And Simi Bukal from our staff is going to help facilitate the questions. And Simi, if you want to unmute yourself and let me know if any questions have come in, and I'll see if I can answer them.
Hi. So question 1, as the states choose their new benchmark plans by June 1st, do you know whether they might have to defray the costs if they choose a benchmark with an infertility mandate in it? Or is it understood that the federal government will still include an IF mandate as an EHB?
Okay, that's such a great question. So right now, the only guidance that HHS has provided is that that pay-for waiver is through December of 2016. Again, that's for mandates that have been in place since December 31st, 2011. We have not received any guidance on what happens in January of 2017, and certainly with the new benchmark plans being formed. So it sounds a little like the chicken and the egg. The states are going to be asked to pick a new benchmark plan, but they're not going to know if that waiver is in place. In fact, my guess is that HHS will come out with a comment about this pay-for waiver later this year. This is so low on their priority list, and it does not seem to be, quite honestly, a big concern of how the states are going to pick their benchmark plans. And so my guess is that they'll pick those plans, and then at some point buried in some sort of rule or guidance from HHS later this year, they will have some comment on if that pay-for waiver is extended past December of 2016. So I hope that answers the question.
Great. Next question. Is there anything for us to do to influence our states to pick benchmark plans in June that have IF coverage?
That is a great question. The benchmark plans are chosen by, typically by the insurance commissioners. They're not chosen by legislators. And so it might be a very good idea if you're in a state with an infertility mandate to have a meeting with your state insurance commissioner's office, let them know who you are and that you care about this particular mandate. It also might be interesting to ask them some of the questions that I've posed and say, gee, do you even know how you would calculate the pay-for clause? How would that work? Do you know if states have been asked to do this already? Again, our information is that that answer is no. And then to talk about encouraging them to choose a benchmark plan that would include the infertility mandate. If your state already has a benchmark plan that includes it, then I would absolutely tell the insurance commissioner that you support what's in place and you hope that changes are not made.
Next question. What can clinics do to help?
Well, I think there's a couple of things. One is to financially support Resolve, and I know that doesn't sound like very much, but that's makes a huge difference in our ability to stay on top of this issue and to help people get organized and knowledgeable. Secondly, I would put some content on your website about the mandate and about the Affordable Care Act, and you can link to our content. We actually have a really great frequently asked questions that's geared towards patients, and I would highly encourage them to do that. And then I would ask them to reach out to me at Resolve and let me know you're interested in working on a state coalition. The state coalition would be formed by providers and others as well as patients. And one of the things that I think we need to do is remind our legislators how important the mandate is and make sure that we have friends in the state legislature so that if there are any concerns, that they know who to call, and also if there are opportunities to improve your mandate and, for instance, bring it into compliance with federal requirements, we want some champions in those state legislatures to help us. So there's actually quite a few things that states can do and clinics can do. So I would encourage them to reach out to me and get content on their site and support Resolve.
Can you explain more what a benchmark plan is?
Sure. When HHS decided that the essential health benefits were going to be determined by each state, they told the states that they had to choose a current health plan offered in their state, and they had 10 choices. Those 10 choices, and I'm taking this off the top of my head, but the 10 choices were the 3 largest large group plans in your state, the 3 largest small group plans in your state, an HMO plan, the state employee plan, and the federal plan. I think that's only 9, so I'm missing one. But in essence, what HHS said was, you pick, and these are your choices. And so each state could pick their essential health benefits plan based on one of those 10 choices that HHS gave them. Now remember, this is each state. So the largest small group plans and the largest large group plans could vary from state to state. So in essence, we were looking at potentially 50 different essential health benefit plans. So what the state did is once they picked one of those 10, that became their benchmark plan. That became their essential health benefits plan that was offered in their state and at their state exchanges. So whatever benefits were included in that were now going to be offered as part of the state exchange. There was some other guidance that HHS had regarding, this was in the original law. The original law had 10 different buckets of types of care, like habilitative care and other types of care. And most plans do cover a lot of the things in those 10 buckets, but the states had complete discretion to choose which one was going to be their benchmark plan. So in the case of Maryland, they chose their largest small group plan as their essential health benefits plan. And in Arkansas, they chose their HMO plan as the plan they were going to use for their essential health benefits. Many, many, many states did not choose. This was a surprise to HHS. These were primarily states that did not like Obamacare, and so they defaulted to the federal exchange and what was in the federal plan.
Next question. Do you know how much Autism Speaks spends on working on the ACA issue?
I don't know the dollar amount, but they have 3 full-time staff that just work on mandates, and they have lobbyists, paid lobbyists in several states, not all, but in several states. But I do not know the dollar amount of their budget for those 3 staff. They travel almost 100%. Those 3 staff, they're literally in state capitals. A different state could be every day. They have certain states that they're working on right now. They have a really cool map that shows all the mandates that have passed and then the few states that are still left, as well as the states that they're currently working on. But again, 3 full-time staff and lobbyists in several states.
What do you tell patients when they ask about ACA, and what can they do on this issue?
Well, that's a great question. From my perspective, it really only matters in states that have a mandate, because if they are wanting insurance coverage for infertility and their state has a mandate, but maybe they work for a self-insured employer, or they're, for whatever reason, their employer is outside of the mandate, then I would have them look into what would it cost for them to buy insurance through the state exchange as an individual, and would that get them the coverage that they need since they're not getting it through their employer. That's a lot. That's a lot of work. It's a lot of research, and we don't have the resources to be able to help to advise people in picking and choosing, but that's certainly something that people could do. If they live in a state that does not have an IVF mandate, and there's only 8 states that do, then there really isn't, the ACA really doesn't help them in terms of opening up coverage. And in terms of what can they do, I would ask them to continue to work with their employer, talk to their employer about adding coverage voluntarily. Some of the states that are outside the IVF mandate have large self-insured employers. They can pick and choose the benefits that they offer to their employees. So if you work for a company, you're a huge advocate and can influence the decisions made by that employer in terms of the coverage they provide. And Resolve is going to be working very hard in this area, and we'll be having a lot of resources for themselves within their company, and also provide you with some great tools and information to talk to your employer. So that's really, in my opinion, the best thing you can do that will provide you with coverage that doesn't involve the ACA.
Okay. If the fertility mandate is not in the benchmark plan chosen, how is the mandate applied?
Yeah, so remember, the essential health benefits in that benchmark plan only are for the individual and small group market in that state. So the mandate still exists, and the mandate still requires employers to offer that. So in the large group market in those states, the mandate still applies. It does not go away. Most of the states, their employees are covered by the mandates, so that would still be in place. So again, it would only impact the individual and small group market. Well, of course, that's large, a lot of people. I'm not discounting it, but the mandate doesn't change, and the mandate still exists, and the mandate still covers and requires employers to cover it. So it would just mean that maybe if you had worked somewhere that had been under the mandate, they drop their insurance, and they tell you, you've got to now go buy insurance on the individual market through the state exchange, then you'd be out of luck. But for the most part, we're not seeing that happen yet, and the mandate would still apply.
Okay, and last question. How many staff does Resolve have for advocacy?
0. We do not have a government affairs staff, and we do not have any staff that just work on this full time. Several of us dabble in advocacy, myself included, but we have a lot of volunteers that help in this area. But from the staff perspective, we do not have any staff 100% dedicated to advocacy and government affairs. We don't have the budget right now to do that, and we, I think, need that, and hope that the community generously supports Resolve so that that is something that we can add as a skill set for our organization. Any other questions, Simi? All right.
That's it.
All right. Thank you so very much. We have recorded this, and it will be available for download. We'll send the link to everybody and also promote it for others who may not have had a chance to join us today. These were excellent questions. I hope this presentation was informative, maybe a little frustrating, but I hope it gave you some updated information on the Affordable Care Act and its impact on the infertility state mandates. Thank you so much for participating. Bye-bye.